that is on end of life care and ethics. This will be taken by Dr. Sunil, who is our palliative care physician. He did his fellowship in palliative medicine from Amrita Institute of Palliative Science, and he did his MSc palliative care from Cardiff University, UK. He has around 19 years of experience in palliative care, and now he is working as an additional director of Trivandrum Institute of Palliative Science. Uh, he is a well versed person in this field. Sir, welcome and over to you.
Yes, sir. Am I audible now? Yeah, audible.
Yeah.
There is some problem. Are you able to hear? Your audio, video is blinking.
Good evening, sir. Sweetra said actually earlier your voice was not at all audible. Now also I believe there is some disturbance. There is a breakage.
Good afternoon, everybody. I hope I'm audible now.
Yes, you are, sir.
Okay. Today we are going to discuss the last topic, but don't think this is the least important one. But this is the most important topic, one of the most important topic in palliative care. So it is end of life care. So this is a little bit difficult topic for us also. So before moving into the topic as such, end of life care, I think there are certain terms which we need to be clarified, because these are some terms which are used interchangeably. So you can see end of life, terminally ill, or terminal care period. All these three words are used interchangeably, and this indicates that the care during the last few months of life. Whereas an actively dying patient means the survival chance is only a few days. Okay, so end of life, terminally ill, terminal care period, it's the patient may last for months, but whereas actively dying means the chance of survival is only a few days. This is why I told you this is a very difficult topic, and I am going to ask you a very difficult question, which I don't know how many of you have ever thought of this. So how many of you have thought of this? You can post your response in the chat, yes or no. I would like to see more responses. Okay, yeah, I can see one no now. Yeah, why I ask this question is, only if we have thought about our end of life, then only we can actually understand what we are going to talk about. So we should see this not from a patient perspective, but from our perspective. So is end of life care or end of life is important for you? What do you think? If so, if you think it is important, from what aspect you think it is important? For whom all this end of life care is important? What do you think? Yes. So we know that end of life care is very important for the patient, isn't it? The person who is dying. Because why it is important for the person who is dying? So the patient might have many sufferings, not only from the physical point of view, but also from a total suffering point. So he should get relief of all this suffering as much as possible. So for the patient, it is very important. For the family, it is going to be very important. Suppose after the death of a loved one in the family, after some time, when we look back, what happens? What do we actually visualize then? We will actually see the last moments of the died person, and that thought, he died in pain, or he died in breathlessness, or he died in a lot of suffering, that will come to our mind frequently, and that is going to haunt us. So it is very important both for the patient and family. Is there anybody else it is important? Is it important for us, the healthcare professionals? Can you explain why it is important for you as a healthcare professional? Anybody? Sarah? Please
Yes,
unmute.
I
Yeah.
would say it's important because death is a part of life. So that a part of being a nurse is caring for a patient throughout their whole lifespan. So we need to know how to take care of them and just help them well through this transition. And also it affects us too. We want to have good closure with caring for our patient. We want to know that we have done all we can and done what we ought to have done to make them comfortable and address their needs, because we have a relationship with the patients that we care for too. So it's important for us as well.
Yeah, very good explanation. So it is not only important for the patient and family, but also for the medical professionals. So suppose if I ask you to choose one for you, which one are you going to choose if you are going to be end of life? A or B? Which one do you like? I can see two A's. B, Sushama. B, yeah. Can I ask Sushama why she selected B? Sushama, I can see all the others have selected A, whereas Sushama has selected B. Where is Sushama? Sushama, please unmute. Okay, there might be some problem, but I would ask the people who commented A, can they tell us? Okay, can any of the others who selected A can tell us why they selected A?
Well, I selected A because it looks like the patient is at home and she's being cared for by perhaps a caregiver or a family member. She's being given some water, and the other person is in a hospital and he has all the medical equipment, but it looks like he's alone. And also in the hospital, we have the way of being able to keep someone alive indefinitely if they have a ventilator and whatnot. So I would not want my life to be prolonged that way for an extended period of time. And I also would not want to die alone.
Yes, thank you, Sarah. So even I would select A, and there would be even more specific points while we select the situation A. And Sarah has beautifully explained why she selected A. And none of us want to be alone in the ICU with the beep of many machines, and there are many strangers with uniforms. Nobody of our near and dear with us. So all these are reasons why we would like to be at home. Another important thing is that if it is in the hospital, we should get some, or we will be getting some care from the nurses, medical care. But it is also important that if the patient is at home, there should be somebody who can take care of the medical aspects. So this is the importance of maybe the palliative care, home care, or even telehealth, which can actually help the patient while the patient is at home. Next. Okay, so what we saw is something called as good death. Okay, so what is good death? So all of you might be thinking, can death be a good one? So there is something bad death also, or painful death. So here you can see the patient has got good symptom control. She has good management of the physical problems, and she is involved in the decision making process. The family members actually participated her in the place of death, and also asked her what would she like to be, where would she like to be, and who all should be with her. So all this, and actually what type of treatment she would like. So there should be a clear decision making, and the patient and family is prepared for death. So in our culture, Sarah, where are you from?
I am from the US.
Okay, so there is a lot of cultural difference. In our country, usually the patient would not know that he or she is dying, and it is actually communicated to the family usually. Maybe a minority of patients would know that they are dying. So it would be very difficult for the patient to be involved in the decision-making process. But still, we would do that as much as possible. And we know that the importance of spirituality or existential issues in the while the patient is dying. So we should also make a chance for them to spiritually grow during this time. And it is also important that we should actually ask the patient to tell the story of the patient to us. So you can see how the patient has born and brought up and how he has reached till this stage. And there will be many important points, or there will be many achievements that patient has achieved. So we can actually stress those points. Okay, you have done this good things, or you are such a wonderful person, like that. And maybe the patient may also like to resolve some conflicts which has happened in the past. Maybe with a best friend, they had a quarrel. Those things, this is the time during which we need to resolve. And the patient should get time with family so that we can facilitate goodbyes and all other things. Then some people, they want to actually contribute to others. Maybe they might be writing a will, or even it may be knowledge transfer. So contribution to somebody else is something which is going to enrich the patient's life. And when we take care of the patient, we should understand the patient as a person, not as a case. So we should value the patient, and we should also understand the patient's preferences, so that we will actually now respecting the patient as a person. Okay, so these are the components which is described as the components of good death. So actually, the patient whom we saw, or many of you have selected the picture A, where actually this is what is happening. Okay, good death. So this is something which is relevant to India, according to the quality of death index, which was done by Economist Intelligence Unit in 2015. I can see India is in the 67th position out of 80 countries that they have surveyed. And so from this, we can understand that India is not a good country to die. If you want to die, go to some other country like UK, Australia, New Zealand, Ireland, Belgium, US in the 9th position. So the quality of death index, they have actually taken into account the what is the palliative and healthcare environment in that country, and what are the human resources available, and how affordable is the care to the people, and what is the quality of care. And they have also taken consideration of community engagement. So all these 5 points they have surveyed, and they have come to a conclusion that India is in the 67th position. So that's the importance for us to understand the end of life care in India, or that's why we are talking about end of life care. So now we are moving on to end of life care process. So in the end of life care process, first of all, we have to understand that patient is now terminal. So how we can understand that patient is terminal? There are some symptoms and signs which are suggestive of patient is being terminal. Then there should be team consensus. So there might be a few doctors and few nurses in the team. So those are the medical people in the team. So if they have conflict each other regarding the patient being terminal or actively dying, then there will be problems. Somebody might be prescribing something, and the other doctor is going to cancel that prescription, and the nurse is going to be in another direction. So those things need to be solved. So that team should have a consensus regarding that this patient is now, we can call them as patient is actively dying or terminal. And next thing is a discussion with the patient and family about the situation. And then thorough documentation of the discussion. What has you discussed with the patient and family? And then we have to ask the patient and family that what do you expect during end of life? So the preferences of the patient and family need to be discussed here. Then the treating team as well as the family need to come into a consensus. Then we have to actually provide end of life care. Then when the patient dies, we have to provide death care. And we know that after death of the patient in palliative care, we usually provide bereavement support for the patient, for the family. So we will move on to the first step. What are the symptoms and signs suggestive that patient is terminal? So all of you are people who are working with patient. So can anybody tell me what are the symptoms and the signs suggestive of that patient is terminal? Breathlessness, death rattle. Yeah, death rattle is a definite sign that a patient is actively dying. Gasping. Yes. Anything else? Loss of appetite. Loss of appetite, that can even occur, even for us, isn't it? Deteriorating vital signs, yes. Reduced urine output, yes. Yes, those are correct. Yeah, next. So you can see either the patient is semi-conscious or comatose. We know that during when the patient is actively dying, the patient consciousness will change. They will be going from the state of alertness to semi-conscious, and then they will be comatose. Patient is unable to take anything orally, including medications, food, or fluid. The patient is spending most of the time in the bed, unable to move, or they are not interested. Next. So they are actually detached from the surroundings. So they do not usually speak to anybody else, as they don't seems to be interested in the surroundings. So Sarah has already told failing vital signs, and there is no response to questions and no spontaneous verbalization. So these are the some symptoms and signs of the patient is dying or near end of life. So at least 4 of this indicates that the patient is dying. So all of you know these signs and symptoms, but these are I just put it into in some groups, and from this 4 signs or symptoms indicates that patient is actually dying. So what are we going to do on discussion on expectation of patient and family? So it is very important that we should discuss the place of care with the patient and family. So sometimes there will be conflict between the patient and family. What we do is in terms of autonomy also, there are some cultural problems here, because the family is going to be with the patient all the time, and it is actually the family who will accompany the patient everywhere till the end. So the autonomy of the family also need to be considered. Whether the place of care should be at home, hospital, or nursing home, this need to be discussed. And there will be a lot of medical interventions available, like ICU care, ventilation, pressure support, all those things, failing blood pressure. So we should actually discuss what would you like to do when these things happens, and are you going to opt only for the proper symptom control during the end of life? Then many patients will have many unfinished things. So we should also actually discuss with the patient to find out if there are any unfinished things, and if there is, if possible, we should facilitate to close those things. Then what are the last rights the patient would like to have? So according to the religion and culture, it may vary, but we should be able to facilitate these things. And if the patient has expressed any wish, we should also consider that, because sometimes they might be semi-comatose or comatose, and they will be unable to express their wish. So even we should ask the family member, has he expressed any wish in the past? And if the patient is not in a condition to express their wish. We told that we should talk to the family and patient regarding the chance of death. So should we actually need to talk about that? And is it, can we do it in our culture? So I would like to show you a video. So please watch this video.
Before we move on to the video, I humbly request Sister Anupama K to kindly check the device, because it is getting unmuted regularly and the faculty is finding it difficult. Sister Anupama K, kindly check your device and please do keep it muted. Still unmuted. Request you to kindly keep your device on mute, please.
So any of you have discussed end of life care with any of your patients? No, I can see Anju says no. Anybody else? Have you discussed end of life care with any patient? Sarah says yes. Okay. What do you think? Yeah, I can see many no's. So, what is your experience, Sarah? If you have discussed this with the patient.
Well, I think there's a lot of fear of the unknown. Like we saw in the video, the patient was expressing fear because she didn't know what to expect. There were some things on her mind. So I think giving the patient the space to express those things is very important. And also just trying in whatever way you can to facilitate meeting their goals. Like I had a patient once who was dying of liver disease. She was not a candidate for a transplant. And the doctors had said, you know, she'll probably die within a couple of days. And she had a broken relationship with her daughter. So she was waiting for her daughter to come see her to just try to reconcile a little bit. And so finally the daughter came around 10 o'clock at night. So I just tried to give them lots of space, and the daughter had about an hour visit, and then I could see that the patient was very visibly at peace after the visit. And the patient asked me for a glass of water, and her diet was still that, you know, usually liver patients are on a fluid restriction because they have so much swelling, but I could tell that she was at the end of life. So I said, yes, absolutely, you can have a glass of water. So I gave her the glass of water, and I checked back on her a couple hours later, and she said to me, "Good night, thank you for taking good care of me." And I checked back on her a couple hours later, and she had died with the glass of water still in her hand. So it made, that was a sad experience, but a good experience of kind of, you know, guiding her through this experience and helping to give her time with her daughter and meet some of her wishes, like just to have a simple glass of water. So, yeah.
Thank you, Sarah, for sharing that personal story. And as nurses, I think you are the most important person, because you are going to be with the patient for all the time. Doctors or other healthcare workers could be there only for some time. So actually, I think you can enrich the patient's experience a lot. And that's what Sarah has done. And you will be able to help the patient in many ways. So I would like to ask anybody from India, what do you think about talking to patient regarding that they are dying? Anybody from India? If I ask you to talk, to a patient, what would be your feeling? Nobody? Okay. It is not a common thing to talk about that to the patient in Indian culture. By most of Sony says it is very difficult. Yeah. So let's see how can we talk about the death of a patient. Next. So we should be very open and genuine to the patient. Patient might be at the end of life, and they might be asking you, am I dying? And sometimes you may tell them that, no, you don't have any problem. So you should not do that. So you should give the clear answer. You should be genuine. Next. And when a patient asks something, encourage them to talk so that we can understand their insight about what they think about their problem. So rather than explaining by themselves, first find out the insight of the patient and then only give proper information. Then we have to elicit concerns of the patient. So even in this video, as well as Sarah told that it is everybody will fear of the unknown. So even we had a child who was near end of life, and actually he asked, he was very fearful. And when we asked him, what he told was, if I die, how am I going to breathe? So this is what was worrying him. So when explained it properly, he was at peace. So we should not be cruel. Whenever we talk, we should talk in with empathy, and if possible, make empathic response. And this patient already asked how long I am going to live. We should not be giving a correct time frame or specific time frame. You are going to die within a week, or you are going to die on 15th of this month. No, we cannot predict that. So what is advisable is give the time either in days or weeks or months. So don't give specific time period. Okay. So in this, the doctor has explained to the patient that probably you have only days to live. So that's the way you should communicate with the patient. And we know that we will not be able to predict the death accurately. So we should acknowledge uncertainty. We should tell the patient it would be very difficult for you to be in this stage because I am unable to give you a correct time. And we also saw the life review in this patient by the doctor. So this is something which we need to stress on. So help them to understand that they have lived a very good life, or the life was work, and it has helped many people, so that it will give some peace for the patient. So next, I'm moving on to symptom management at the end of life. So these are the common symptoms which we encounter. That doesn't mean that there are no other symptoms which we have to manage, but these are some common symptoms which occurs at the end of life. So pain, breathlessness, delirium, and death rattle. So suppose the patient is taking analgesics like opioids. So do we need to actually continue the opioids? What is your opinion? Anybody? Yes. Yes. Okay. So what we have to understand is that we have to continue the analgesics, and if the patient is very much comatose, and maybe you may reduce the analgesics to 2/3, but never discontinue, because if you discontinue the analgesics, that is going to make more difficulty for the patient, and the patient will be restless if you discontinue the analgesics. So it is advisable to continue the analgesics, and sometimes they may not be able to take orally. So you have to give it either subcutaneously. We usually give it subcutaneously, and intravenously rarely. And another route is parectal. So you can administer morphine parectally. And delirium is another important symptom that occurs during end of life. And there is something called as terminal delirium. And if you see a patient, or if you have seen a patient for a long time, and you see that patient has an advanced disease, and patient has developed delirium, probably that might be a terminal delirium. And it says about 88% of the patients can have delirium when the patient is dying. So if the patient has delirium for a patient who has advanced disease, please think of whether it is due to the patient is going to die. So terminal delirium is not reversible, and it is due to multiple factors. There is no single point involved in terminal delirium, so we will not be able to reverse it. And we have to symptomatically manage delirium. So most important is we should not use any restraints, specifically mechanical restraints, because in ICUs, many patients are tied to beds. It should not be done, because that is going to actually increase the delirium. We can actually use antipsychotics if needed, if the patient is really agitated. Otherwise, maybe non-pharmacological management would help the patient. So death rattle is another definite indication. This is because the patient will be unable to swallow saliva or secretions because the swallowing reflex is lost. So when the air passes through airways and throat, there will be a particular gurgling sound, which is known as death rattle. And how can we manage? It's actually, we should manage it non-pharmacologically mostly. As seen in the video, actually it is not a problem for the patient, because patient usually will be unconscious. But it will be a concern for the family. Family might think that my loved one is suffocating, is unable to breathe. So we should explain to the family that the patient is not feeling any discomfort, and why it is there. It is due to pooling of secretions in the throat and not due to breathlessness. So this explanation is very important. And how can we manage this if it happens? So keep the patient in recovery position, either in left lateral or right lateral position, so that the secretions will flow out due to gravity. And you may even use a gauze, which is wound up on a handle of teaspoon or toothbrush to remove the secretion. So if non-pharmacological management fails, then you may use either injection hyacinth butyl bromide or injection glycopyrrolate, which are anti-secretory. But this is not going to dry up the secretions which are already formed. So this will reduce the formation of secretion. Okay. Yeah. So we'll move on to a patient story. Mrs. X, 60-year-old woman, is diagnosed with advanced cancer of the stomach. She is in her last weeks of life. Her appetite is very less and not eating much. Family is compelling the patient to take food. Patient says, I don't have much appetite and family is compelling me. As she is not taking much food, family want us to put feeding tube. What should we do? Any comments? So this is a common situation which actually the caregivers will come to you, to the nurses, and will tell you. What would you do? Patient wish. Okay. Educate the family members that patient is nearing end of life and we should not force feed. Okay, thank you. Anybody else? Open and genuine. Yeah. If patient is willing, then only. Okay. Okay. So no need of hearty feed. Okay. So first of all, I would like to ask you, why should we eat food? Why should we eat something? Yeah, we need to have energy, isn't it? Next slide. Next. So from a physical point of view, we should eat to get energy, then only we can sustain the life. Yeah. Is there any other aspect with which we have to eat food, or we is eating food? From a psychological point of view, do you eat food? Yes. Suppose you are going to a hotel and you are eating something, and then you see that another person is having an ice cream. Then you will also think that, yeah, I would also like to have an ice cream. So that's from the psychological point of view. And from the social point of view, if I go to any home at Kerala, they will actually compel me to have a tea. So it is not to reduce the hunger. That's the social need. Okay. The other one, psychological need. This was the social need. And from a spiritual perspective also, if you look at when we go to temples or any other church or something, then we will get some offerings. We would eat that, usually something sweet, and that is from a spiritual perspective. So we are eating food not only from the physical requirement, but also from the psychological, social, and spiritual aspect. So how can we address the force feed? We have to actually understand, and when you force feed any person, can it produce any harm? When the patient is at the end of life. So yes, indigestion. Yeah, anything else? Okay, from a physical point of view, if you force feed the patient, it can actually vomit. And if there is a patient who is vomiting, who has no appetite, usually the diagnosis will be the caregivers are force feeding the patient, and the stomach, the fullness, it can occur early, and that can cause breathlessness. Even it can cause pain, and aspiration is another thing which can occur. So these are the physical problems or physical harm that we are going to produce by force feeding. Next. From a psychological point of view, usually the patient will be angry and worried, isn't it? So when suppose you have taken your favorite food and it is full, and nothing will go now. So your friend is coming and telling you that, Sripriya, we are meeting after a long time. Will you take, shall I give you some more biryani? she will say, no, no, please, I have enough. So after some time, he will again ask, Supriya, no, you should eat. Supriya will tell, no, no, I don't want. He's again asking, no, I don't want. Supriya, please. No, I don't want. So the patient will become angry and will also think that the family is not understanding me. And from a social point of view, previously, whatever the patient told, the family was obeying. Now nobody is obeying the family and they are compelling me. And spiritually also, the patient will feel that they don't understand me. So these are the harms which can be produced by force-feeding a patient at the end of life. Next. So is it going to do any good for the patient if you force feed? So you can see a tree on which plant parasite has grown. And at first, that tree will not have any problem even if there is plant parasite. But after some time, what happens? The plant parasite will take out all the nutrition from the plant and the plant will be destroyed. So at this time, if we put some manure for the tree, is it going to benefit the tree? No, it is not going to benefit the tree. And a patient at the end of life or when the patient is terminal, this is the situation. So this is how you can actually explain it to the family. Next. And you can also tell this natural thing to the patient family. When you were a baby, you were taking only milk, and after some time, you were taking a little bit of food. And then when you are adolescent, you are taking full plate. And as the age advances, the food will reduce. And when the patient is bedridden, they will take only half glass of water. And after some time, it will be teaspoons. And when the patient is actively dying, it will be sometimes like drops. So this is the natural thing which usually occurs when the person is dying. And so this is something which you have to explain. And when the patient doesn't need any food or air, then we call it as death of the patient. And this is the scientific basis behind loss of appetite. When a patient has a chronic disease, there will be a lot of inflammation happening in the body, and there will be some chemicals released, and which acts in the satiety center of the brain, which will reduce the appetite. So this is what is happening to the patient. And so then the family will ask, if he don't eat, how is he going to live? So this is a question which you will face. So you can see that people like us, we need a lot of energy because we are working, running, thinking, doing many things. So we need a lot of energy. But a person who is dying, he just need only very, very less energy because we are not moving the energy only to sustain the body functions. So even if he's eating something, some fluid or very small amount of food, the energy will get from that. So this is the explanation that you can give to the family. And after explaining this thing, you can ask the caregiver that, what do you think? Is it going to, is force-feeding going to help the patient, or is it really going to harm the patient? And sometimes the patient caregiver may tell you that, I understand, I will not force-feed. But if somebody says, no, I understood, but still I cannot see that my loved one is not taking anything. So you tell the caregiver that there are two options. One option is that the patient has to suffer because you are force feeding him, or and you can continue to force feed the patient, your loved one, so that the patient will suffer all the physical, psychological, social, and financial, spiritual problems. Otherwise, you need to suffer. And if you are not going to force feed, then you will be worried because your loved one is not taking. So you have to worry. So the choice is yours. You can select, either you can worry or the patient has to suffer. So choice is yours. So this is how you can actually manage the situation. Next, 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 next. So first of all, you can actually empathize with the caregiver, telling that you are really worried that your loved one is not taking anything, isn't it? So that would be an empathizing statement. Then you can ask, find out the concerns of the caregiver. Next. And then you explain those things, the plan, what are the risks and what are the harms involved, and ask the caregiver about what is the benefit, what is the harm of force feeding, and then give the choice to the caregiver, even though we want to be with the patient. Next. So next, I'm going to talk about a little bit of ethical aspects. So what is ethics? These are some moral principles which governs our practice. This is not legally binding things. Okay. So mainly there are 4 ethical principles. One is the most important one is patient autonomy. So respect patient choice. So whatever the patient says, it should be done. We have to do that. That's what patient choice means. So for a disease, there will be many treatment. The patient says, after explanation of each treatment, patient says, I would like to have this treatment. So it is our duty to respect that choice. Yeah, that is known as patient autonomy. Then we should do the treatment which is going to benefit the patient. And we should, when we do a treatment, we should be able to minimize the harm. We should, whatever be the treatment, we know that it can cause some harm, but we have to weigh between the benefit and harm. And if the benefit is more, we have to continue the treatment. The next principle is justice. So these are the 4 principles, but in justice, there are 3 types of justice: distributive justice, legal justice, and right-based justice. Distributive justice means, suppose we have 2 situations where one situation is that a patient who has an advanced lung cancer, he has only days to live. He was brought to casualty. He is having severe breathlessness. This patient, the hospital has, this patient is brought to casualty with severe breathlessness. This patient was sent to ICU by the casualty medical officer and was put on a mechanical ventilator. The hospital has only 1 ventilator. Okay. So after some time, another patient was brought. He had a road traffic accident, and he also needed the ventilator. Or suppose this patient, both of these patients comes together. Which patient would you give the mechanical ventilator? Which would be your choice? RTA. Yeah, accident. Yeah. So this is known as distributive justice, because we know that the patient with road traffic accident have a better choice of recovery. So the mechanical ventilator should be reserved for that patient. So that is what is known as distributive justice. And legal justice means there will be some laws governing our practice. So like in India, there is Medical Termination of Pregnancy Act, so which we have to bind with. So that is legal justice. And right-based justice, for example, suppose a patient who is known to have chronic obstructive pulmonary disease, COPD. This patient, you are working in a hospital, and this patient used to come to you for getting absence from the work. So they have to produce a medical certificate, and you are the person every time that was giving. And whenever they come, you have actually told them that you are smoking, and that's why you are getting this exacerbation very frequently. So you have been doing this for the past 1 year. So are you actually, do you need to give the certificate for getting absence from the work if the patient has exacerbation of COPD due to smoking? What's your opinion? Anybody? Yeah, you have to give the certificate because we know that it is because of smoking, but we only need to look whether the patient is sick enough to get absence from the work. So that is known as right-based justice. It is the right of the patient to get absence from the work when they are sick. Okay. So in case of the patient who with the caregiver are force feeding, so how would we come to a ethical decision with these principles? So we should actually ask the patient, what does he want? So the patient says, I don't want, actually this patient says, I don't want to be on a Riles tube. So that's the patient's choice. Then we have to look at the benefit. Are we going to benefit the patient by putting a Riles tube? We know that there are many side effects or harms which can actually produce by putting a Riles tube and feeding. And we also know that there is no benefit. So that means if you weigh between harm and benefit, it is more of harm. So we should not allow or we should actually deny that procedure. Because we are the healthcare people and we have to decide about the treatment. Suppose if you feel that this is going to produce more of harm, then you can actually deny that treatment. Okay. Yeah. And in the end of life, do we need to continue medication? So you have to actually review all the medication, continue only those medications which are going to make the patient comfortable. So that means many of the patients will be on antiplatelet medication like aspirin, clopidogrel, then hypercholesteremic, anticholesteremic medications like atorvastatin, rosuvastatin. All those need to be discontinued. You can actually continue only those medication which makes the patient comfortable, like analgesics, okay, or medications for breathlessness, etc. And if the patient is is actively dying, we need not do any investigation because our focus is now comfort. And the ultimate aim of end-of-life care is a dignified death. So I think I will show you another video, and with that we will end the session. So even though we may not have discussed many things regarding symptom management and things like that, but from those two videos, I think you might have got many important points. So I think I will stop the session here. And if there are any burning questions, I can take. Anybody has any comments or experience or any doubts? Shiva, it's over to you.
Okay, thank you, sir, for the excellent session. I think they all understand well through your session and video how to take care of an end of life care patient. So our main aim is we need to understand that our main aim is to treat an end of life care patient is to improve, maximize their comfort level. So, sir was mentioned about the common symptoms, pain, breathlessness, delirium, and death rattle. These are the most common symptoms, but some other symptoms can also happen, but you have to understand that how to take care of that symptoms through the pharmacologically and non-pharmacologically. And at the same time, you have to understand that the patients, the caregivers concerned, so they are going to lost their loved ones. You have to understand their emotions and listen to them and talk to them and understand their emotions and communicate with them well, so that they can also get some kind of support. And also you have to think about the bereavement support also. After death also you have to, if possible, you can go and see the family and see their emotional factors, and if they have psychosocial issues there, you have to give some better support, and you can give counseling, and if they, usually the grief period will be there, but uh, if that grief is persisting, sometimes the patient, where the caregivers will be going to in depressions. You have to treat well, so you have to identify those things. If you are not able to go their homes, you have, at least you can make a phone call and find out how are they, and are they feeling good, that kind of things you can do it. So all of other things sir has took well, and in simple language you all understand well. Thank you, sir, once again. Uh, if you don't have any questions, this is our last day session. Your feedback is very essential for us. We need to improve our courses. If you have any suggestions or any feedback there, please share with us so that we can able to improve our classroom sessions and all. This online, this especially this is the online session, we need to improve. Based on your suggestions, we will try to improve. Thank you.
Thank you, Mr. Shiva. Thank you, Dr. Sunilkumar. Hope I'm audible, Shiva ma'am. Hope I'm audible. Can someone please confirm? Good evening, everyone. Thank you, Shiva ma'am. Thank you, Sunil sir, for that wonderful session. With the first note that Sinia has conveyed her warm greetings to all. She could not make it today because of some medical emergency, so she could not, who have been coordinating all the sessions, she could not join today. This is Sri Priya on her behalf. So as coordinators, now for the last, maybe we have 4 minutes left, we would like to hear from you. What all you felt would have been better in this program, what you felt was very good in this program. So we would like to have kind words from at least 2 or 3 of the participants. If someone could volunteer, please. I can see the chat boxes, but still, if someone could express their feelings, their thoughts in words, we would be grateful.
Sessions are very good and very informative. There could have been a little more discussion, I think, if everybody, because of the disturbance, I think we couldn't have audio chats. But if there were possibility of audio chats, it would have been better. But even I couldn't put my audio off when I had, because of the disturbance. Yeah, but otherwise, sessions are very good. I learned a lot.
Thank you so much, Sister Lilakandi. The point is well taken. We do understand that there were many audio disturbances in between in some sessions. And yes, of course, we will have a word with our technical team regarding this and see what can be done in the coming sessions. Thank you so much. Anyone else?
Yes, I really appreciated this course as an opportunity to hear how palliative care is done in South Asia. Most of my experience has been in the United States, but I'm part of a team that's helping to start a palliative care program in Bangladesh. So this has been very informative for me and Onita Di, who is also on this course. So we will take what we've learned and apply it in the South Asian setting, which is still a little bit new to me. I especially appreciated the sessions where the presenters talked a little bit more. They didn't just read off the slides, but they shared stories or gave examples. And that's helpful because, you know, I think we all can read, but to have discussion, I really enjoyed especially those sessions.
Thank you so much for those words coming from the US, Sister Sarah. Yes, we do understand, like, even though it is virtual and many times the faculties are facing difficulty, like they are talking to the blank screens, the black boxes, but still they try to make it. We will definitely share this feedback with all the faculties involved so that instead of reading out plainly from the slides, we will definitely improve our sessions that the discussions are more. The slides will be less, the words will be less, but the interactions will be more. The point is well taken. Sarah ma'am, thank you so much. Maybe we do have time for one last feedback from any one of the participants, kind words.
Actually, being a nurse, everyone knows how to take care of the patient. Fundamentals we all learned, but after joining in this course, we are taking care of patient very much in all aspects, not only in care of the patients, each and every patient, whatever the age it may be, we are taking it in a physical, psychological, emotional, and spiritual aspects, so that we are communicating more. Our communication improved. So the patient and patient parties, they are feeling very comfortable after we are going little bit depth. So this session improved our professional care a lot. Really, it's very helpful for us, madam. Whoever given that faculties, everybody explained very well. And after that, any network issues also, we go through that whatever that given for us, they shared in mails and all in our time after that our duty hours we gone through. It's really wonderful preparations, everything they given for us. um, it will help us in future also, and entire our service, it's very helpful to us. Really, I thought online session means how it will go like that, but timings, everything is very good to all the persons, whoever in duties also, weekly twice. From the time to till that end of the course, it's went awesome, madam, and it's really very useful entire our profession, not only in profession also in ordinary life also, natural life also. It's very useful to us how to communicate with other persons or patients. Thank you so much, madam. Thank you so much. I am very grateful to join in this session. Thank you all, ma'am.
Thank you, Sister Sujita. We are really happy to know that we could make a difference in at least some lives where you interacted with people, and this course had enabled you to interact better to your patients. We are really happy to know that. And I believe we are 2 minutes past the regular time. So of course, this doesn't end here. You can definitely share your feedbacks to us over WhatsApp, over email, or in the group. Shiba ma'am, would you like to add any final notes?
Yeah, so as all of you mentioned that this course is very beneficial to you all. So I uh, want to say all of you is you have to try to include this palliative concept in your daily practice, and share your knowledge with your colleagues and friends, so that our palliative care, that awareness is also there. They will understand more about palliative care. So best wishes for all of you, and if you have any doubts or anything, please contact us again. We will help you too. Okay, thank you.
Thank you, Shiba ma'am. Sunil sir, as the additional director of TIPS, would you like to say any closing comments to our participants?
So I am happy to understand that at least Sister Sujata told us that she has actually incorporated the palliative care principles into her practice, and that made a lot of difference. So we are happy to hear that, and I'm sure all of you are going to integrate these principles into your practice, and it's our privilege to have you with us for this 20 sessions, and together we will make this world a better world. We know that we talked about quality of death index. So maybe those who are in India or abroad, they can try to help out the patients who are really suffering. So thank you for being with us for this 20 sessions.
Thank you, sir. So it is not only to Priya guys, but we are saying to everyone that yes, of course, if you face any difficulty in handling difficult pain or difficult people around you, we are there. You can get in touch with us over email or WhatsApp, as I said earlier, and we do have an exclusive telehealth department functioning in Pallium, India, who are accessible to telephone call as well, which is a free service. So it was indeed our pleasure to have the real angels in earth with us for the 18 sessions, and we do hope that you keep spreading smiles everywhere you go and make lives pain-free. This is Sri Priya, along with Sister Shiba and Dr. Sunilkumar and Mr. Anu, signing off from the Tips Echo Hub for the last time, but please do stay in touch with the social media platforms available. Thank you, everyone. Stay safe, stay happy, stay healthy, keep spreading smiles. Bye-bye.